Good morning, everyone. Welcome to the PG lecture series. We are currently having a lecture series on medical oncology. And today we have a lecture on approach to cancer of unknown primary. We are privileged to have Dr. Deepa Susan Joy Phillip join us for the lecture today. She is an associate professor currently in the Department of Medical Oncology in CMC Vellore. She has done her MBBS from Trivandrum in 2004 and had won 24 gold medals then, followed by her MD General Medicine at Lady Hardinge Medical College in New Delhi, following which she did her DM in Medical Oncology at Tata Memorial Hospital, Mumbai, where she was a gold medalist for outstanding student. She thereafter continued to work at Tata Memorial Hospital in Mumbai, following which she also worked at the Regional Cancer Center in Trivandrum for 7 years. She's now joined our center, and we are privileged for her to have take the lecture today. I welcome her to take the lecture first. Thank you, ma'am.
Shall we all stand up in silent prayer for a minute? Okay, please be seated. We can start, right? Others will be joining by soon. Okay. So, dear students in varying stages of metamorphosis in the healing and teaching ministry at CMC Vellore, a very good morning to you all. As Sakshi has presented in detail, I'm Dr. Deepa, and I would say I'm a 6-month-old baby in the CMC family. Many of you would have listened to the famous advertisement of Onida. Have any of you seen? Or it was, I think, probably in my era. It used to say that it's honor's pride and neighbor's envy. And there was one interesting character which used to jump over the TV and all that. So that's what I feel when I'm back to medicine to interact with MD kids after a long period of time. So today, the topic we are going to discuss is what you call as CUP, that is cancer of unknown primary. My first point is a word of thanks. I would say thanks for hope. HOP. It's definitely a hope for me. It's probably a hope for you, the MD kids, after a long time. And I sincerely hope and wish that it is not a hope for you, a hardship, ordeal, and punishment early in the morning, empty stomach, when you have lots of things going on in the wards. And of course, the purpose is to help oncology patients everywhere. So when I'm standing here, after the first 5 minutes, whoever be the speaker, even if it's Mark Antony himself standing here, after 5 minutes, this is the thought that is going to come to your mind. When is this lady going to stop? So don't worry. Of course, I understand that this is an IPL lecture where it is an immediate pre-lunch lecture. So we have, when you say about a class, I think this is a second in a series of oncology classes which you are going to have. I'll definitely say that this is what a class is. Most of our classes, right from our school days, where you have a passive transfer of information from the teacher's notes to the student's notes. And this is important, without passing through the brains of either. And we know the hordes of notes we have, which we never open in our lifetime. And in 2024, things have changed a bit. So it will be transfer probably from the laptop to an iPad or to a tab. That's the only difference. So keep your paper, pen, everything down. We'll just have a contributory, structured discussion with an open mind where you will be doing more of talking and I'll be doing less of talking. So we'll have a journey through the evolution, or rather, it's the revolution of cancer as far as oncology goes. And we'll have a short quiz or a pre-test to assess how much you know about oncology, especially about the concept of CUP. So it will be a guided tour through the wonderland of oncology. So when you hear the word cancer, what is the first thought that comes to any of your mind? I don't want anyone sitting here silent. You all will be speaking, opening, and you can say any blunder, that's perfectly fine. What is the first word, the first thought that comes to your mind? No, I'm not talking of the physiology, the mechanism. As a layman, the word cancer, what is the thought that comes to your mind? Yes. So the feeling that everybody gets is a feeling of scare, right? I also had the same thing before I joined oncology. We'll come to that. So we react in different ways. Some are scared, some will feel sad, some will feel envious. And if it is your enemy, you will feel happy, okay, he should get that. Not me. There will be people who feel that way also, maybe. And when you have a diagnosis of cancer, it is usually taken as a death sentence by the patient and by the family. Mind you, we have lots of cancers which are close to 100% curative, but still it's taken as a death sentence. And the patient and the family becomes a pile of ashes. So it's important to know about cancer. Now, the second question is, when you hear the word cancer, or suppose I'm a patient with cancer and you are my treating oncologist, what are the two questions which burning in my mind, which I will ask you as the oncologist? Yes. Yes. So the two questions which will burn in your mind as a cancer patient, which you will be asking your patient, your doctor would be, one, what cancer do I have? Meaning from top to bottom, which organ of my body the cancer has come from, right? And you will have answers to it: lung, liver, bone, brain, like that. The second question, which every patient will ask you, is what is my stage of cancer? Is it an early stage or is it an advanced stage? Right? These are the two questions which usually patients will ask you. Now, coming to the second question first, what stage of cancer? And the doctor tells you, you have an advanced stage of cancer, what we technically call as metastatic cancer. I'm sure you have heard about the word metastasis in pathology and everywhere. So stage of cancer is advanced. Now I ask my oncologist the second question, which cancer do I have? Or rather, which part of my body the cancer has come from? And my oncologist tells me, I don't know. So that is exactly really a burning problem. You have an advanced cancer, but I'm sorry, I don't know from where your cancer has come up. So then what happens? This is what happens. We already said that diagnosis comes as a death sentence. So it's like a double death sentence, or it's rather like a lightning striking the patient twice in his lifetime consecutively. So that is the important challenge we are going to discuss today, which is called in the fancy term of CUP cup, that is cancer of unknown primary. So the second question is WIIFM. What is this? First you are thinking, when is this lady going to stop? I'll stop, don't worry. I will not go beyond my time. Second is, what is in it for me? So what? There is some cup, let the cup be there, let madam manage, let Ashish sir manage, let oncologists manage. What is in it for me as a medicine postgraduate student? So what is she going to speak about which is of relevance to me? So we'll have 5 points which will be discussed in the next 30 minutes. The first point is a thanks. I'm sure many of you will be feeling relieved. Thank God, one point is over. Second is, what is CUP? Third, why this concept of CUP happens? What should be your approach to a patient? And most important, how are you going to manage a patient with carcinoma unknown primary? So, what is CUP? Why this concept of CUP happens where the primary disappears and the metastasis keeps growing? How do you approach it and how are you going to manage your next patient with CUP? So, what is or what do you understand by the concept of CUP, cancer of unknown primary? Anyone? Yes. When you hear the word CUP, in your, you don't need a great definition or anything. What do you mean? CUP. Yes. Mm-hmm. Sure. Okay, sure. Very good. So when you see CUP, it's cancer of unknown primary. So one, there is a cancer. So there is a biopsy proven, histologically confirmed malignancy is there at the metastatic site. You know what metastasis is, right? There's a primary and there is a metastasis. So the patient has a biopsy proven cancer at the metastatic site. But what is the problem? The primary site of cancer is still unknown after a good comprehensive evaluation. So we had a biopsy done, we know it's cancer, we did a good comprehensive evaluation, but we do not know where the primary is. So that is called as CUP. So I'll explain it with an example. So here, what do you see? Here you have an elderly gentleman who has presented with a right cervical lymphadenopathy. Biopsy is done and it is proven as carcinoma. So what do? Even before you touch the patient, we'll order for a CT, we'll order for a PET CT and a lot of things, right? That's not the ideal thing. We'll come to that. So CT is done and it has come back, it has come as normal. So you have clinically right cervical node, pathologically proven adenocarcinoma, radiologically there is nothing else except for that cervical node. So this entity, where you have a cancer confirmed at the metastatic site, primary we do not know despite a good comprehensive evaluation. That is what is called as CUP. I hope the concept is clear to you. So this is a simple way of understanding the concept of CUP. Imagine you're walking on the road, not such a busy road like this. Maybe in a remote area, you are just walking. You find a child who is crying, standing in the side of the road. And the child is crying and saying, I'm not an orphan. So what do? First is TLC. You give tender loving care and try to console the child. Then you take history from the child, about to know the whereabouts of the child. Then you'll ask people around whether they saw the child with anyone. All that fails, then you inform the police. They do investigations. So in the same way, and finally, when all this fails, we think that probably this is an orphan and the child is handed over to a child care home. So why it is important to know about CUP is because one, it's a very aggressive disease. Two, it disseminates very early. Three, always there will be a point in our mind. We have that doubting Thomas in our mind, thinking, is it that I'm not good enough? Is it that my evaluation is incomplete, that I'm not able to reach a primary? Outcomes are very poor, and of course, it has a very uncertain clinical course. That's the reason why we need to know about the concept of CUP. This was a survey which was conducted among Australian oncologists. Around 100 of them, they were asked, what do they feel about the concept of CUP? Most of them, what they said is, I don't tell my patient it is CUP. What I say is there is a mother and a child. The mother is a primary, the child is a metastasis. We have found the child, but we are yet searching for the mother. So these are different ways in which people put it. Coming to the third interesting point, why do we get CUP? Meaning you have a big metastasis sitting there. What happened to the primary? Where did the primary disappear? So To understand that concept, you can think of a very simple, common analogy. Imagine that you are on duty. Usually your duties go on like 48 hours, 72 hours. So after 3 to 4 hours of duty, you have come to your room, or your house, which has been locked for some time. You enter your room and you find a puddle of water in the middle of your room. So what could be the differential diagnosis? The doors, windows, everything is locked. It has been locked for 4 5 days. It was raining. It was rainy season, like below. Rain comes and goes. We never know when it comes and when it goes. So what could be your differentials? We always think of differentials, right? So when you see the mystery of the puddle of water, what are the differentials that you would think of? One, you would think that probably you looked up, there are no crevices there. Probably there's some water up, some small crevice which is so small that you can't see it. Second, you look at the window is closed, but probably the window was open. We could have had a good neighbor, a good Samaritan, who would have come and closed the window so water didn't come in. Third, there could be some tap which was leaking. And the water is over, so the tap is no more leaking. So the same analogy, if you take, there may be a small crevice on the roof which you cannot see. The primary is so small that it cannot be detected by the usual investigations. Second, I said there's a window, rainwater can come in, but a good Samaritan has come and closed the window. Our immune system is so good that just like closing the window, it's taking care of the primary. Third is like you have the leaking pipe and the water is finished, you can have a burnout primary. These are some of the mechanisms. Now coming to how will you approach a patient who comes with carcinoma of unknown primary? This is how you are going to approach. There's one picture on the left bottom that is the most important thing. Cup should always be approached with empathy. And that is, we'll come to that. As far as a clinical evaluation goes, it is C, P, and R. Or you can remember as CRP or as CPR. Clinical, pathology, and radiology. So first is clinical, second is radiology, and third is pathology. These are the three ways in which you are going to approach it. Clinical, I don't have to elaborate. I think you all know. Then you have radiology and pathology. So this is what William Osler said. Our eyes will never see, our ears will never hear, our hands will never feel what our minds do not think of. So unless and until we know what to specifically look for in our history and examination, we are going to miss out on important things. So the most important thing is clinical evaluation. So when you look at it, many of you have your Littmann's test with you, right? Which is the most important part of the stethoscope. Yes, the part between the two earpieces, that's the most important thing. And that is where clinical evaluation becomes most important. So what you have to train yourself to be is to be a doctor for whom you will be confident to go to if you become sick or your loved ones become sick. That should be the level of empathy and the level of clinical acumen we should be developing. And for evaluating cup, we have to be very observant for minute details. Never hesitate to communicate with your colleagues, with pathologists, with radiologists. Don't keep thinking pathology has not come. Please pick up the phone, talk to your pathologist, talk to your radiologist, and always work as a team. The clinician, radiologist, pathologist, everyone working together as a team with an open mind and with the mindset of solving a puzzle by a detective. So we'll have a few case series at the end where you will be detectives trying to solve the puzzle of CUP. And most important, your evaluation should be time bound. This should not be what is happening. You keep evaluating. Finally, you get eureka, you get a diagnosis. And that should not be at this time when the priest is giving the last rites. So your evaluation should be time bound and with empathy. So in history, three things. One, 3S you have to remember. One, site-specific symptoms. Two, surgeries in the past, which the patient might have forgotten. I'll come to that. And three, spontaneous regressions. You specifically ask for these three histories: symptoms, surgeries and swellings in the past, and spontaneous regressions. To put this, or rather to hammer this concept into your brain, we'll discuss a case. This is a patient whom I saw in my first year of DM training in TMH. As usual, we get all these consults, and by the time I went to see this patient, it was, I think, 2 o'clock in the morning. So he was a 28-year-old gentleman who was admitted with respiratory distress. And this was his X-ray. You all know what it is, right? This is what you call as cannonball appearance. Okay. Biopsy was already done by the treating department, and it was reported as poorly differentiated carcinoma. CT scans, evaluations all done, except for what you see in the lung, everything else was normal. So what do you think the primary is? You'll think it's lung cancer, right? He's a 28-year-old young male. You think, okay, it's stage 4 lung cancer. So a consult was given to my department for giving palliative chemo. So at 2 in the night, I first thought, okay, I'll give right chemo. Then I thought, okay, I'll just take a history, which we do, no, right? Once in a while, especially when you feel like doing. So I thought I'll take a history. So at 2 o'clock, I woke up the patient, woke up the relative. They were shouting, screaming at me. Then I asked them to show all the papers of all the treatment which they have received over the last so many months. So they gave me a huge bundle of paper. Because of my OCD, I went through all the papers and I found one paper here. This is not that patient, this is another one, which stated that the patient had undergone an orchidectomy a few months back. And I think that was in CMC, orchidectomy was done. That's the first time I saw a CMC discharge summary, the detailed one with a lot of pages. So this was done. So I showed him, this is yours, right? He said, yes, 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 surgery was done. So I asked him, why you didn't tell anyone? Oh, that is important. I didn't feel it was important, so I didn't say. So then I went through it. So it was a history of orchidectomy. He was advised chemo, but he was lost to follow up. So this is where history becomes important. Before this history, he was a stage 4 adenocarcinoma lung for palliative chemo. Now, with this history of orchidectomy, we have a metastatic disease called, what is a tumor we call? Testicular germ cell tumor, which is a highly curative malignancy, even in an advanced stage. So that is where history, especially history of past surgeries, becomes very important. So site-specific symptoms, surgeries, and spontaneous regressions. These three are very important. Coming to clinical evaluation, I think you all are very good at it. Specifically focus on swellings, skin examination for any nevus, head and neck examination, breast examination in females, pelvic examinations, and rectal examination. Now coming to lab investigations, a complete blood count, the usual biochemical investigations that we know. What is important is to remember about tumor markers. I'm sure you have heard the term tumor markers, read about it. What do you know about tumor markers? Do you think it is diagnostic? Yes or no? No. Yes? Everyone is silent, sleeping or meditating or listening. Very good. Like? Sure. So for a tumor marker, as you rightly said, if you have the last ones, AFP, beta HCG, if you have a beta HCG in lakhs, what malignancy does it denote? Provided patient is not pregnant. Yes? Very good. So if beta HCG is say 1 lakh, 2 lakhs, you don't need anything else. You don't need biopsy, you don't need anything. It is choriocarcinoma. So you have tumor marker CA125, which is more suggestive of ovary, but none of these are diagnostic of malignancy, but it helps with monitoring. Now, to speak about tumor markers, I'll tell another case. This also happened, I think, in my first or second year of DM. A 24-year-old lady was admitted in ICU. She is on a ventilator and probable diagnosis is it's viral infection followed sepsis followed by ARDS. Now this is the X-ray, again cannonballs. You see only mets, you don't see any lung there. So there was a very clinically sound and smart intern not me, somebody very smart and very intelligent, elicited a very important history and did a very simple bedside test, a very quick test. You get the report immediately to diagnose a condition, and she was cured. Can you say? I think 2 minutes back, some of you had spoken this. I'll give you a clue. It's related to tumor markers. But are sleeping. Nobody's opening the mouth only. Yes, I said about something in lakhs and all that. Yes. So, a young lady with acute respiratory distress, hemoptysis. There was a history of a recent abortion around 6 to 8 months back. And the test that was done was a urine pregnancy test. So for a lady who is not pregnant, you do a UPT and you find that it is positive. So that is because of beta HCG. Of course, you can do beta HCG assessment in the blood, but suppose a patient comes, say, on a Saturday evening when the assay is not happening, especially in your, not in a tertiary center like this, but in other centers where you may practice, you may not have beta HCG around the clock. A simple test is a UPT. So a diagnosis of choriocarcinoma was done. Patient was treated with methotrexate and she was cured of a malignancy and she is fit and fine. So that is clinical, is very important. Next is radiology and third is pathology. So in radiology, what is the first investigation which you would do? Even before you touch the patient, in your lab orders, you will start ordering. Yes. PET CT, you don't. Chest X-ray, oh, very good. Chest X-ray, okay. Because whatever I said so far, all those diagnoses were made just on a chest X-ray. And mind you, even if you had done a PET CT, those two diagnoses would not have been made if history was not taken. So you did an X-ray, then please, investigation is important. Okay, so X-ray, ultrasound, and we are justified in doing a contrast enhanced CT of thorax, abdomen, and pelvis in any patient to evaluate a carcinoma of unknown primary. Now, will you do PET CT? I thought all of you will scream and say PET CT, but I think you all controlled yourself and didn't say. So is it wrong in saying PET CT? You do it, right? Yes or no? We'll see. And of course, you can do clinically directed imaging. Like suppose a lady presents with an axillary node. You can't palpate, you can't find a breast lump. Of course, you will do a mammogram and you would do a breast MRI. So nobody spoke about PET CT. So we have the ESMO guidelines, which says that there's nothing wrong in doing a PET CT, but there are two situations where you should definitely do a PET CT. They are 2S. The first S is you have a patient presenting with a cervical node. You did a biopsy, it came out to be squamous cell carcinoma, and you don't have an obvious primary. So that is the first S. Squamous cell carcinoma in a cervical node. Second S is when you have a solitary metastasis. You have evaluated, you found only one site. So you want to go ahead with a curative intent of treatment. There again, you can do a PET CT to make sure that you don't have any other site of disease. Okay. So we have a 40-year-old lady. She has presented with a right axillary lymph node. Biopsy has come as adenocarcinoma. Clinically, you palpated, you didn't find anything there in the breast. A mammo is done. Mammo is also just suspicious. There is nothing definite. So you can do a breast MRI in that situation to make sure that we are not missing a breast primary. So that is the importance of a comprehensive evaluation. So first we did a clinical examination. The 3S you remember, right? Symptoms, surgeries, and spontaneous regression. Clinical examination from head to foot. Never forget breast examination and pelvic examination in female. Then we came to radiology, X-ray, ultrasound, contrast enhanced CT of thorax, abdomen, and pelvis, PET CT, especially in those two situations, and symptom directed investigations. And those were all non-invasive and clinically directed endoscopies may also be needed. If you have upper GI symptoms, you may need an upper GI endoscopy. You may need a lower evaluation with a colonoscopy, bronchoscopy, and all endoscopic evaluations as well. So coming back to our first case, clinically, there was a right cervical lymph node. Biopsy was adenocarcinoma. A PET CT was done, and there was no definite primary. So that takes us, so clinical is over, radiology is over. That takes us to the last point, and that is pathology. What do you see here? There is a cup with different pathology patterns written on it, right? How many of you liked pathology? Nobody is even looking at me. Yes, I find 2-3 people. Okay. So how my pathologist friend is going to help me is, first, when you have the biopsy, you would look at what H&E staining. Second is what is called as IHC. Have you heard the word IHC? Immunohistochemistry. And third is molecular profiling. We'll not go into the details, we'll just touch upon them. And most important thing is this, tissue is always the issue. So you do a core biopsy, you get a little bit of scanty tissue. And what you do with that tissue is very, very important, because we can't keep on biopsying the patient again and again. So tissue becomes a real issue, and you have to judiciously use it between the 3 investigations. This is how most of the time the slides look like. There may be some scanty malignant cell sitting, or maybe jumping from one slide to the other, sticking to one corner, and then you keep calling pathologists, give the report, give the report. So only if there is an adequate tissue, the pathologist friend will be able to help you out. So what the traditional pathologist does with an H&E stain is what we clinicians do with history and physical examination. So the first H&E staining and morphology is the most important thing. This is what we are supposed to see. And you remember your good old pathology days when all the slides, I hope there are no pathologists here. So all the slides used to look the same. And sometimes we would look at how the slide looks, whether there is a cut on this side, cut on this side, and try to find out whether it is squamous or adeno, right? Okay. So this is what you're supposed to see, and this is what we most of the time see, and this is how you will write. I can see some circles in pink and violet. Please correlate clinically. That you can't give, right? Because the whole patient's life depends on this report. So you can have different reports. You may get adenocarcinoma, you may get squamous cell carcinoma, you may get a poorly differentiated tumor, undifferentiated tumor, different patterns you can get on H&E. So I'll give one another very interesting patient. I wouldn't say interesting because what had happened to her is very unfortunate. She's a 15-year-old girl. She's retropositive, had presented with rapidly progressive abdominal distension. She presented with ascites and with renal failure in oliguria. The first investigation, as usual, PET CT is done. It's not here. It's in another center. PET CT is done, which showed there is ascites and there is ovarian mass, which is hypermetabolic with uptake on PET CT. No biopsy done. THBSO was done in the village or in the hometown from where she came from. Any guesses what this could be? A young girl. She's retropositive. She's in renal failure. I can say she's in tumor lysis. She has a bulky mass. Yes. It's a very curative malignancy, highly chemosensitive malignancy. It's a very favorite question in all NEET and all exams. If I ask the cytogenetics, I think you would say translocation 814. Now you will say, yes. So that is, and the starry sky. So this was basically, this is the biopsy where you have the typical starry sky pattern. And this was Burkitt's lymphoma. And remember, Burkitt's lymphoma is a highly curative malignancy. It's a very aggressive malignancy, which doubles in 24 hours. But you can cure patients with chemo. So in this patient, surgery was futile, and we can say surgery was not needed for this patient. So why it is important is if pathology is not done, you will miss out on highly curative malignancies and label them as unknown malignancies. So that is where the next investigation called immunohistochemistry becomes important. So when you think of pathology, remember three headings. First is HND, second is IHC, and third is molecular profiling. So in IHC, I will not go into details. First, what you do in IHC is you try to find out what type of tumor it is, what you call as lineage assignment. What family does the tumor belong to? What are the different families of tumors? Different types of cancers? Carcinoma. Bucket is what? Lymphoma, sarcoma, melanoma. Okay. So first level of investigation will be to see which family it broadly belongs to. And second, we'll do more tests to localize the tumor further. So IHC should always be used judiciously. Why? Because if you keep on ordering one test after the other, it's a very costly thing. So we should not be penny wise and pound foolish. So we should always think clinically, radiologically, and then think of what judicious IHCs to be used. And most important, it should be planned in such a way that you get a time bound report. You can't keep on running IHCs, running tests one after the other to get a report after 2 months when the priest is giving the last rites to the patient. So it has to be a timely report. So this you should remember because we are talking of CUP. So when you in H&E stain, you see carcinoma, say adenocarcinoma, one IHC which you would do is what is called CK. CK is cytokeratin, which is done for carcinoma. So carcinoma is CK, and for lymphoma, it is LCA, leukocyte common antigen. So this is the whole panel. I've purposefully put it upside down. Even if it comes straight, I don't think it will make any difference to any of you. So that's okay. We will not discuss that. And of course, if you have an adenocarcinoma, there is something called CK7, which is positive for all the sites which are developing from the foregut. So if you have an upper GI, lung, all that would be CK7 positive. So if it is from colon, that would be CK20 positive. And then you have different permutation combinations of CK7, CK20 with a whole table, which my dear students in Ranipet have to by heart. But fortunately, I don't think that is expected from you. And there are certain ones which are very important in the preview of CUP. One is like the elderly gentleman we discussed in the beginning. If you do an IHC called TTF1, what is TTF1? Thyroid transcription factor 1. That is suggestive of two primaries. One is what? TTF. T is thyroid. So one is thyroid and the other is lung. So thyroid and lung adenocarcinoma, that is TTF1 positive. Rest you have a long list which if interested you can go ahead and read. So far, do you have any questions? We discussed what is cup. Then we discussed why we developed cup with that puddle of water. Then we discussed the approach. First is clinical with history and examination. History, symptoms are important. Surgeries in the past is important. Spontaneous regressions are important. Head to foot examination is important. Radiology, we spoke about CT and PET CT. Then in pathology, first is HND, second is a judicious IHC, and the third very important one in today's day and age is molecular profiling of tumor. Most of you would have heard of a concept called NGS. We will not elaborate. I think you have a separate class on lung cancer where that would be elaborated upon. So when the tumor is getting smart, what do we oncologists have to do? We have to become smarter. Earlier, everybody was treated with the same chemo as a one size fit all. But now what we do is we do a tailored approach where we try to crack the code, and in the DNA we find specific mutations which would act as potential targets for treatment. Previously, all lung cancers were treated the same. Then adeno and squamous became different. But now the way patients are treated is it's divide and conquer. So you find out specific targets, divide patients into different groups and treat them accordingly with specific targeted treatment. That is where precision medicine and personalized medicine comes, where we treat with the right drug at the right time, at the right dose to the right patient. And this is the mutational landscape in lung, which you have a separate class on. And there are various tumor agnostic markers as well, which can also help in treating patients. For example, if you have MSI high tumors, you can give immunotherapy and the like. So just a word on NGS. For patients with carcinoma unknown primary, of course, NGS is important in the evaluation. Make sure we have adequate tissue in a core biopsy. If the patient has only fluid, don't send 2 ml, 3 ml, 5 ml. How much fluid you have collected, send the whole fluid so that a cell block can be prepared out of it. And most important is, if the patient is unwell, start treatment. Please don't keep waiting till you get an NGS report, which might take close to 3 to 4 weeks. Fine. So this is in nutshell. You have a patient who has come with a metastasis. First, you search for the primary. Most important, never ever miss out a curative disease like the Burkitt's lymphoma, which I mentioned, germ cell tumor, which I mentioned. So never ever miss out on that. And then you evaluate and find that it is a true CUP or a true carcinoma of unknown primary. So I think many of you are feeling sleepy, so I'll give you some job. Who is feeling sleepy can come forward. So finally, why did we do all this? You have to treat the patient, right? So cup is like a basket where you have different fruits, right? So some cup will be behaving like a colon, some will be a breast-like cup, some will be a kidney-like cup. So it's, you don't have a primary, but it behaves like that particular primary site. So you can learn the entire oncology if you treat one single entity in oncology, and that is carcinoma of unknown primary. Whose quote is this? Death is a single best invention of life. I think his invention is there in many of your bags and hands. That is Steve Jobs, who did most of his great inventions were done after he was diagnosed with a malignancy. Your time is limited, so don't waste it living someone else's life. That's what he has said. So when you have the entity of cup, where you have a metastasis that's biopsy proven, you did a very good comprehensive evaluation, which we discussed so far, and yet we do not have a primary. So that is the basket of cup. Now what you need to do is, you have a lot of entities in it, just divide it into two groups. One is a good cup, which I would say that red is good. So this is a red cup, which is a good cup. And you have a black cup, which is a bad cup. So all the entities in cup have to be broadly divided into these two, because that is important for treatment and that is important for prognosis. The good cups may survive for years. The bad cups, the patients would survive maybe for days to months. So how do you remember which are the good cups? So this is a backronym, B CHOPS. We'll come to that. So how are you going to manage these patients? The first and most important thing is the patient is in pain. Don't keep evaluating. Symptom control is the most important thing. Adding life to days is important, but adding life to the days that the patient has is equally important. Nobody cares how much you know unless they know how much you care for them. Second is the psychological support. I spoke about the double death sentence in the beginning. So psychological support is very important, and there are support groups specifically for CUP. So it's a broad basket. You divide it into the good cups and the bad cups because it is important for treatment decisions. In oncology, we have lots of treatment options. As I said, there is evolution and revolution going on. So out of all this, which should I use for my next patient who is diagnosed with carcinoma unknown primary? This is how guidelines go. Good and bad cup. I'm sure when you see this table, you will switch off your brain. But don't worry, it's a very simple table. First, let's take something bad. So when you have a bad cup, that constitutes 80%, where the patient doesn't do well. Survival is usually in a matter of few months. There, assess the clinical status of the patient. If the patient is in a good clinical condition, give chemo, which is usually a blanket chemo where you give a doublet. You need not know the drugs and all. Usually it is a platinum-based doublet, either paclitaxel carboplatin or maybe gemcitabine carboplatin. Chemo drugs are given. What we will focus on is the favorable or the good cups because you should not miss them. So how I remember it is, you can remember it as B chops. B chops are the good cups. B means it's a breast-like cup, like the one which I said in the beginning. In the breast, there is no primary. The patient has a right axillary lymph node. All evaluation, including IHC, is suggestive of a breast primary. So breast-like cup. C is a colon-like cup, means all the evaluation is like that of a colonic malignancy, but there is no primary in the colon. Head and neck malignancy, ovary, prostate, and if you have a solitary site of metastasis. So that is B CHOPS. I hope that is clear. So why it is important is each of them are treated like that particular disease. So if you have a breast like CUP, there is no breast primary, but you will treat like a patient of breast cancer. You have a patient of colonic malignancy, we will treat it like colon cancer. So site specific treatment is given for the good cups, and for the bad cups, it's basically do no harm, palliative care, and chemotherapy based on patient's tolerance. So this is the same thing. And when you have the unfavorable group, that is where one, if patient is fit, you give chemo. Second, NGS becomes important because if you are able to find a target, which you can easily target with medications. So we have guidelines. I can share it with you in case you have the time, you can go through that. So finally, I think most of you were awake, you were not sleeping. So we'll have a post-test, just 1 or 2 cases, just to see how much you have gone through it. I call post-test as pearls because more than for you, it is for me. You can see a pearl there, right? So what is pearl? Post-test evaluation is to assess your retention. And of course, it's an assessment for my teaching and learning skills as well. And when you hear the word pearl, what comes to your mind? Not oncology, philosophically. How does a pearl form? Where is a pearl formed? Inside an oyster, right? So what does the oyster do? A grain of sand enters the oyster. What will we do if we are in the place of the oyster? We'll crib, complain, scream, and curse the poor sand, right? But what does a oyster do? The oyster transforms that irritation, that setback into a very beautiful pearl. And that's what we should also be doing in life. So clinically, radiologically, and pathologically, all the three needs to be correlated. So coming back to the first patient, elderly gentleman smoker, clinically right cervical node, radiologically PET scan is normal, biopsy is adenocarcinoma. So the workup which I taught you, what will you do next? Yes. Clinically, there's a right cervical node. Biopsy is done, adenocarcinoma. PET scan is done, it is normal. What next? Yes, very good. So this is what we have so far. So what was done was IHC was done. So in IHC, CK7 is positive. And what is the IHC marker for lung? Adeno, TTF1. So CK7 is positive, TTF1 absent positive. So that means the patient has an adenocarcinoma lung like carcinoma of unknown primary. And what was done for the patient was molecular profiling was done, and the patient was found to have an EGFR mutation positive. So for EGFR mutations and deletion positive patients, you have targeted treatment. That is, many drugs are available. One of them is erlotinib. It's a tablet, and the patient is on the tablet for the last 2 years. So here, the patient has a cup, but a tablet a day is keeping the cancer away. So that is the importance of evaluating and working up the patient in a timely manner. So those were our 5 points. First was thanks. Second, what is a concept of CUP? Cancer unknown primary. Why there is cup? I hope you remember the analogy of the puddle of water. What is going to be your approach? Clinical, radiology, and pathology. Always identify the good B jobs and please don't miss out curative malignancies. Identify the bad jobs and the bad cups early and focus on adding life to their days. Cancer is only going to be a chapter and it's not the whole story. And no one cares how much we know about cup unless we make the patient feel how much we care for them. I'm sure this is your state. Time is slow when you're waiting, and time is deadly when you're sad, and time is very long when you're feeling bored. I think many of you have started to feel bored. A diagnosis of cancer, as an oncologist, I would definitely say that a diagnosis of cancer is not a death sentence. Even if it's a carcinoma unknown primary, which is one of the most aggressive ones, remember, diagnosis of cancer is never again a death sentence. It's in fact a life sentence which inspires us to live. And this is what happens most of the time. We'll keep on reading the theory, approach to cup, recommendations on cup. And this is what happens. Your knowledge wing keeps on developing. Then, unfortunate, you will not be able to fly. So, what will happen? You will only be going round and round because you are not able to fly. What is needed is you should be having a balanced development, best best extent in the situation and time frame possible. Prayers with beads, best efforts already done by self, where you need to focus on your knowledge, your clinical skills, clinical acumen, and most important, your attitudes and behavior. So between illness and wellness, it's always a teamwork in everything in medicine. When you replace or substitute we for I, what happens? Illness becomes wellness. Well, I dedicate this class to MD students, to the memory of my dear parents, for whom always molding kids to doctors were their passion. So we discussed what is cup, why, approach, how to manage. So it was an immediate pre-lunch lecture, and I hope I'm not still standing between your lunch and so this. I just want a feedback about the class, what you're feeling at this moment. Is it a loving, frustrating experience or is it unexpected? So thank you for your patient listening. And if you have any questions, any comments, anything, it's your free to ask. This is my personal cancer journey. So any questions on cup? If you don't have any question, I'll give you some job. Any volunteers? No volunteers. Come. One of you can come. I can't call dear Sakshi. Somebody else has to come. Come. You can delegate it to your friends also. So in this basket, you have a lot of primaries written. What I want you and your friends to do is divide them into the good cup and you can come here. Divide them into the good cup and the bad cup. You can read and say. Okay. Yes. No, not everyone. You can call one or two volunteers. Come. Please come. One of you. This is fine. So this is the good cup and this is the bad cup. Okay. Head and neck, where will you put? Very good. Prostate, cervix, ovary, chops, bladder, colon. Okay, very good. So I hope it's clear to you. So what is CUP? Why you get cup? Your approach of C, R, and P, judicious use of investigations, and finally managing into good cup and a bad cup. Thank you. Any questions are there? Any questions? So many questions? No. I think 2 minutes are left. Shall we all stand up in silent prayer before we leave?
Thank you, ma'am, for that wonderful lecture. Thank you, everyone, for joining us offline and online. Please join us for lunch. Thank you.